Namaskar. Today we are going to talk about the metastatic bone pain. That means the pain which happens because of the bone metastasis, that is the cancer pain. So, I am Dr. Anurag Agarwal, presently working as pain physician and a professor of anesthesiology at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, Uttar Pradesh, Bharat, India. I have done my MBBS and MD in anesthesiology as well as PDCC in pain medicine from BHU, that is Banaras Hindu University, and I have interest in interventional pain and spine medicine and percutaneous spine endoscopy. I am Vice President of NAPCAM UP chapter. I am also the founder president of Endoscopic Spine and Interventional Pain Society. I have been secretary of Indian Society of Pain Clinicians and I am member of Pain Medicine Board of National Board of Examination of Medical Sciences in India, that is NBEMS. I am also a member of Cancer Aid Society Ethics Committee. So, the incidence and prevalence of bone metastatic pain, that is very important to understand, because until unless you know the magnitude of problem, you cannot manage it. So, bone is the third most common site of metastasis after lung and liver in all kind of cancers. It indicates a short term prognosis, unfortunately. When a patient of cancer is having bone metastasis, you can be sure that patient is not having too much of time. Median survival from the diagnosis of bone metastasis in different studies and different stages of cancer patient is ranging 6 to 48 months. Majority of the skeletal metastases are due to the breast and prostate cancer, that the incidence goes up to 70% of patients. And bone metastasis, that is the secondary cancer lesion, because primary is someplace else like in the prostate or in the breast. So, but the incidence of metastasis in the bones are much more common than the primary bone cancers. So, 70% of prostate cancer and breast cancer patients are likely to have bone metastasis, while 30% of lung, bladder and thyroids, they can also have bone metastasis. And in 80% of the patients who are having bone metastasis, it is likely to be there in the axial skeleton. So, you please remember the axial skeleton, the body is made up of a skeleton, the arm, the leg, they are the peripheral skeleton, like the humerus, femur, they are the peripheral bone. What is the axial skeleton? That is the spine of the patients. So, consequence of this is severe bone pain, pathologic fractures, symptoms of hypercalcemia, or it may cause spinal cord compression, which results in the impaired mobility and deterioration in quality of life. Patient is unable to walk, unable to sit or stand because of the vertebral metastasis. We see day in and day out of those patients. Increased medical cost and negative impact on the survival. So, type of bone mets, they can be osteoclast, they can be osteoblast and they can be mixed, where in the osteoclast there is a lytic activity, that means bone is getting dissolved by the osteoclastic activity. So, bone destruction arises by the action of osteoclast, that happens in the breast cancer. But there can be another thing, which there is increased formation of bone. So, that is known as osteoblastic activity, which is characterized by sclerosis. It usually happens with the prostate cancer. And then there can be condition where both osteoblastic as well as osteoclastic activity is present in the same lesion. So, here you can see in the prostate cancer patient, this is a bone scan picture, where you can see increased sclerosis at multiple level. So, here it is a lesion, here it is a lesion, whole skeletal almost is full of metastasis. So, how to diagnose the bone metastasis? Patient usually complained of the localized pain and tenderness. Then there is a history, you need to take radiological imaging, like they start with the X-ray. Here you can see there is a lytic lesion in the upper part of humerus. Then radionuclide bone scan may be required, biological markers, alkaline phosphatase, multiple blood tests, multiple X-rays, MRI, CT scan, they all are required to make a diagnosis and to provide a treatment. So, as I told you, survival is quite less. In the cancer breast, 70% patients are having bone mets and 5-year survival is only 20% and median survival is 24%, 24 months. In the carcinoma prostate, 75% patients are having bone metastasis, and most of the time 5-year survival is only 25%, but slightly more median survival, that is up to 40 months than the cancer patient. Carcinoma lung, very bad prognosis, 40% are having bone metastasis, mainly osteolytic, and 5-year survival is only 2 to 5%. Same is the renal cancer. Multiple myeloma, again very common, up to 100% patients are coming with the bone metastatic, and they are mainly osteolytic, but 5-year survival is only 10%. So, how to manage the bone pain due to the bone metastasis? You do the local treatment like the radiation or surgery if it is possible, and then there is a systemic treatment where you use the multiple combination of drugs like the hormone, chemotherapy, radioisotope, bisphosphonate, opioids, adjuvants to treat this. And then there is one treatment which is our niche as a pain physician, that is minimally invasive pain and spine intervention, MIPSIs, like cementoplasty, like vertebroplasty, like kyphoplasty, like vertebral stenting system, the latest treatment for to treat this condition. We will show you some cases about this. So, the effect of bone metastasis is severe pain, impaired mobility, pathologic fracture, spinal cord compression, bone marrow aplasia, hypercalcemia, and hypercalcemia specifically is a marker of poor prognosis with median survival of only 10 to 12 weeks, that means 2 to 3 months only. So, as I already told you, osteolytic can be there, osteoblastic can be there, and mixed can be there. So, bone metastases are almost always multiple and involves the axial skeleton, that is the spine in majority of the patient, and pathological fractures happen up to 30% of patients, and most frequent fracture site is proximal part of long bones like the femur and humerus, and then it can be rib fracture or vertebral collapse as it happens with the multiple myeloma patient. So, characteristics are of the pain that they are poorly localized, they are usually worse at night, is a very important feature. Please ask your patient, they are having more pain in the night, that means you need to examine and investigate your patient. Not necessarily relieved with sleep or lying down. Back pain in a patient with cancer with an abnormal spinal radiograph, a warning from spinal cord compression. So, please rule out. To investigate, you need to have complete blood count, serum calcium, phosphorus, vitamin D, alkaline phosphatase, creatinine. So, all these multiple tests, but please remember, if you are working in a primary care setup and you do not have an answer after getting all these investigation to your patient, so please do not get them. Please do not make patient spend their money, whatever amount they have remained with. You please, if you are suspecting and patient is not responding to your primary treatment and you are unable to provide advanced treatment, please refer the patient as such to a nearby pain physician or a pain medicine facility. So, bone scintigraphy, that is the bone scan, is a highly sensitive but has a low specificity. Plain radiograph is very specific but sensitivity is low. So, CT and MRI has a good sensitivity and specificity, and then there is a PET scan also which can be, but they should be employed only when you are thinking that you are able to provide some extra treatment after having the investigations of your choice. So, please do not advise the battery of investigation to your patient, rather it is better to refer the patient to the appropriate facility. So, the treatment starts with the non-steroidal anti-inflammatory NSAID like the ibuprofen and the diclofenac sodium. Second most commonly used drugs are opioids, and here in the bone metastatic pain, NSAIDs are usually more effective than the opioid drugs. Please remember. Then corticosteroids, calcitonin which is a hormonal replacement, bisphosphonate drugs and injection denosumab, that is a RANKL inhibitor, they have been found to be very useful for the management of cancer pain. Then bisphosphonates are considered to be the standard treatment for tumor induced hypercalcemia, and sclerotic lesions like it happens in the carcinoma prostate, they respond equally to the lytic lesion with the bisphosphonate. But please do not remember to prescribe a calcium and vitamin D along with bisphosphonate. Then comes the injection denosumab, this is a new therapy, slightly costlier, but it has been found to be quite useful in the management of cancer pain. So, role of bisphosphonates in the bone metastasis: binds to the site of its active bone metabolism. It is released from the bone matrix during the resorption, and it inhibits the osteoclast activity. It reduces the hypercalcemia and SRE, but pain relief is uncertain. Especially useful for the Paget disease, osteoporosis and bone metastasis. The most common preparation, which is the IV preparation, is being used is the zoledronic acid of bisphosphonate, which is used in the 4 to 5 milligram per month in over 15 minutes. So, there is evidence to support the use of bisphosphonates in providing some pain relief from bone metastasis, but there is insufficient evidence to recommend bisphosphonates for immediate relief as first line therapy. Calcitonin. Calcitonin is used to treat the metastatic bone pain, and few studies are there which fulfill the selection criteria. There is no evidence that calcitonin control the complications of SRE, but there may be some pain relief which may lead to improving quality of life. Then comes the radioisotopes, like the multiple isotopes. This therapy has been given by the radiation oncologists. So, and most of these cancer patients, they are under the treatment of either a radiation oncologist or a medical oncologist or a oncosurgeon. So, most of the time when the patient reach us in the pain medicine OPD, these therapies already have been exhausted in most of the patient. So, there are multiple limitations which can be cost, availability of high-end machines, then there are contraindication when there is myelosuppression, renal function is impaired, spinal cord is compressed, these can be a contraindication. Then comes the radiotherapy for the choice of localized bone pain, and then comes the mechanism of pain relief is poorly understood. If the improvement does not happen by the 6 week or more after the treatment, it is likely to achieve. Radiotherapy has been done, but it is not working, then it is not going to work. So, still it is considered to be the mainstay of painful metastasis, but it usually takes 2 to 4 weeks to take effect, and if after 6 weeks patient is not relieved, it is unlikely to be relieved. What are the other therapies, like the radionuclide therapies like the samarium and other therapies? For that you need to send them to a specialized center which is having a facility of nuclear medicine or radiation oncologists who are providing these therapies. Then comes the role of us as a pain physician, that is radiofrequency and cryoablation, which are the minimally invasive and percutaneous therapies for the use in these patients. And surgery is only indicated when there is a obvious fracture of long bone and hip joint, or there is a impending spinal cord involvement, compression. So, now there are few interventions which are very new, but very advanced and very effective till now as the literature and evidence supports. So, these are the therapies which we are providing at our pain medicine unit at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, Uttar Pradesh, Bharat, to our patients of bone metastatic pain. They are percutaneous cementoplasty. Common name is percutaneous cementoplasty. The aim is to fill the lesion of bone where the metastasis is there, which is causing pain, causing lysis or blastosis, and mixed type of lesion. We fill it with the specialized bone cement, that is PMMA, and to decrease the chances of further fractures, to decrease the pain, and it works immediately. So, this is very important and good therapy to know about, that is, if the lesion is in the spine and it is not compressing the spinal cord, pelvis, ilium or proximal femur or humerus, this percutaneous cementoplasty can be used, and it immediately restores the mechanical stability. It prevents further risk of bone fracture and allows immediate weight bearing. So, this is emerging as one of the most promising procedures for the patient with painful bone metastasis. The best part of our MIPSI treatment, that is minimally invasive pain and spine interventions of pain medicine, is like the cardiology, like the angioplasty. If you remember 20 years back, most of the patients who were suffering from the heart disease used to undergo the bypass surgery. But now, since last 15-20 years, you know that most of these patients are being managed with the angiography followed by angioplasty if required. So that is the same setup, same thing which we are doing with our patients of chronic pain syndrome with the use of minimally invasive pain and spine intervention. They can be equated to the angioplasty and angiography, where the benefit is that there is no big incision, there is no big or long term hospital stay, they are cost effective, immediate return to the normal activity or life is permitted, and with immediate results. So here few cases of ours where you can see that there is a metastatic lesion in the bone and which was later on filled with the cement and patient got immediate relief. Here you can see this is the, and what we do, we did it a cementoplasty of the lower end of femur with the immediate pain relief of more than 80% and full weight bearing after 1 week, and with a pencil rather pinhole incision, no big incision, nothing. So that is known as femoroplasty. Another patient, he was a patient of carcinoma buccal mucosa, oral cancer patient with fracture of D4 vertebra and sacral metastasis. Here you can see that this is the MRI picture of the patient's MRI, and where you can see this vertebra is collapsed, severely painful. Patient was unable to walk, sit or lie down, and then there was a lesion in the sacrum. Here you can see on the left side of sacrum. So because of these two lesions, patient was unable to sit down, walk, lying down even, and patient was more in the night, pain was more in the night. So what we did? We go and we did the percutaneous vertebroplasty and sacroplasty, where you can see our cannula is inside the collapsed vertebra. This black is the PMMA bone cement, and here also in the sacral part you can see this is the sacral plasty, and immediate relief. Patient was walking after 1 week, sitting together, and patient was already under the active oncological treatment. And we have the data of more than 5 years survival of this patient without any pain. Another patient, multiple myeloma with severe back pain and lesions in almost all thoracic and lumbar vertebra. D11, L1 lesions were found to be painful. This is the MRI of a multiple myeloma patient. You can see the almost whole spine is being involved with the metastatic lesions, especially there are two vertebra which are collapsed, D11 and L1. Here on the X-ray also you can see that this D11 is collapsed, this L1 is collapsed, and what we did the vertebroplasty of both the lesion, also took the biopsy, where you can see the bone is filled with the cement, bone cement, and patient was immediately relieved. So the MRI is the investigation of choice if you want to do percutaneous cementoplasty, vertebroplasty of this patient, because it is important to rule out that there is no spinal canal compression due to the spinal metastasis before you attempt these things. When you have any doubt about the integrity of the bone, please get a CT scan done. Like this patient is not our patient. I cannot do a cementoplasty in this patient because this bone is completely destructed. So if I try to put cement in the collapsed vertebra, cement is likely to leak into the spinal canal and to compress the spinal cord, which may result in the complication. So these are the contraindication of cementoplasty when there is a posterior cortical defect, so that cement may leak into the canal. We are not going to do it. So this is my Facebook page with the name of Pain Free India, Dr. Anurag Agrawal, where we do multiple activities to increase the awareness about the available treatment and treatment option for the all kind of chronic pain syndrome, be it cancer pain or non-cancer pain like the low back pain, joint pain, neuralgias, trigeminal neuralgias, and multiple advanced treatment options. And this is our YouTube channel with the name of Pain Free India, Dr. Anurag Agrawal. Again, here we put the original videos for the interested pain physicians of the advanced interventions of MIPSIs which we provide to our patients, as well as the testimonial videos to increase the awareness about the different chronic pain syndromes and their available treatment for the help of society. Because remember, we want to make India, Bharat, a pain-free India. So that is our mission and motto of our life. There is a mail ID, Dr. Anurag11 at gmail.com, and I have shown you my Facebook and YouTube channel. Please follow and subscribe, and if you have any doubts, any problem, we are here to help. With this regards from the Dr. Ram Manohar Lohia Institute, this is my institute where I work at Lucknow, Uttar Pradesh, Bharat. We are having a 1-year PDCC pain medicine course. The eligibility is for the MD, DNB anesthesiology. So, if you are interested and coming from the anesthesiology background and you are interested to join pain medicine to become a super specialist, you can apply to our institute. You can also come for an observership of 1 to 3 months to our institute to see how we work, what are the most advanced treatment options which can be done in the minimally invasive manner to help the patients of chronic pain syndrome. So, thank you all, best wishes for your bright future, and thank you.